Assalamu alaikum. Welcome everyone. Good afternoon. Today, we are going to do the first session of online PAS test 2020. Our topic today will be burn and shock. Okay, before I start, we have 5 minutes to clarify some questions for you all about MRCS Part A. I know that most of you have some questions for that, but I will talk in brief about this topic. Okay, MRCS Part A is formed of 300 questions. 300 questions are divided into two main stems. The first stem is about 180 questions about the basic science. Basic science is anatomy, physiology, pathology, microbiology, pharmacology. Then the surgical technique, which is paper 2, about 120 questions. And this is the most difficult part in the exam, because you have to be trained, solve a lot of questions on paper 2. Paper 2, the most important in it is vascular, trauma, some difficult questions in orthopedic, burn and shock should be management, and also statistics. Okay. Time of study will be around 3 months. You should study well. You have about 3 to 4 hours daily. You do not have to leave your work to study. You can study even at your mobile phone. Okay, MRCS, membership of the Royal College, is your way to UK. You can gain a good job here to get benefit from the UK system. You will know how to learn how to deal with patients. You will learn some important tips for that about patient safety, health promotion, audit, and some difficult words, and this is later on. Don't burden yourself with that now. Okay, then I will deliver some sessions on daily basis. I will try to stick to that on about 3 sessions per week for free for you all, and I will deliver also a permanent link for that on the official YouTube channel. You can see whatever you want. Okay, in order not to waste your time, I'm going to start, but I want active participants with me because I will share the question. I need someone to read it and tell the answer, and we will discuss the answers. But our strategy will be, I will discuss the topic first from zero for you all to gain benefit from the topic, from Hesham notes, and also after that we will discuss the questions of past test and some collected questions from other book. I have collected them for you all. Okay, now I'm going to share the burn topic from Hesham notes. Okay, let's start. Burn, what is the definition of burn? Burn initially is a coagulative destruction of the tissues. What causes burn? There are some physical burn, chemical burn, and inhalation burn. Physical burn may be thermal, electrical, or irradiation. And the chemical burn may be acid or alkali, exposure to corrosive or caustics. The most important here is acid and alkali. You should remember this information now, as they will come in questions in past tests. Acids cause more pain than alkali. Acids cause more pain than alkali. But alkali cause more tissue penetration than acids. So the pain is high with acids and tissue penetration is high with alkali. Also, if you have some powder of an acid or alkali on your skin, don't put water directly on your powder, on the powder in your arm. You should remove the powder initially by any swab, and later on you can pour the water on it. Okay? We have types of burr, and here from our notes, there are 3 degrees of burr. The first degree, which is the superficial epidermal type. Superficial epidermal type, where there is just redness and a slight inflammation of the skin, and it is really painful due to exposure of the nerve endings. Second degree of burr, and it is 2 types, superficial and deep. Superficial, which involves the epidermis and part of the dermis, and deep, which involves the epidermis and the whole dermis. The difference between them is when you see the question, there is blistering, so it is the superficial second degree. You should remember that it is a superficial second degree, or superficial partial thickness burr. There is blistering. But in the deep, there is mottled red color, and it is important for you. But full thickness, which is leathery and desensate. Okay, then to calculate the percentage of burr, initially you will go with Wallace rule of 9. Wallace rule of 9, like you see in this picture, you should remember that all the head and the neck is 9%. The whole trunk anterior, the whole trunk includes the chest and abdomen. The whole trunk anterior is 18, and the whole back, chest and abdomen, 18. Push upper limbs, everyone is 9%, and push lower limbs, everyone is 18. And the perineum area is 100, is 1%. Okay, then like the palm is also question asked in past test. The palm surface area is about 1% of the burr. Okay, this is what's called the Wallace rule of 9. But in children, we use another formula which is called the Lord and Crowder chart, because the head and the neck in children is more larger and obeys a large weight. Okay. Burn also can be classified into major, intermediate, and minor. And this is not written here. Major burn is more than 30% of the body surface area. Intermediate percent is about 15 to 30%. Minor burn is less than 15. And this is the indication of the fluid resuscitation for patients with minor burn, when the surface area of the burn in adult less than 15 and less than 10 in children, no need for fluid. More than that, we will start the fluid resuscitation. Fluid resuscitation here is according to Parkland Formula. Parkland Formula, to tell you, it is not used from 2018. We will go with the Advanced Trauma Life Support Formula. And it is written here in the past test, in the Advanced Trauma Life Support Formula is half the Parkland Formula. The Parkland Formula is about 4 multiplied by the body weight multiplied by the surface area of burn. But in the new criteria of the Advanced Trauma Life Support, ETLS, now it became 2 by body surface area by body weight. And we will use that in our calculation of the body surface area of burn. The most important here also is when to transfer patients to burn center. I'm going to transfer patient to burn center. Any child with even partial or full thickness burn, more than 10% total body surface area, any inhalational burn, electrical, chemical burn, in any adult with more than 20% total body surface area, or more than 5% full thickness burn, or any burn in a premorbid patient, like severely immunocompromised, like hypertension or diabetes. Then we have what's called escharotomy, is the removal of the eschar. Okay, escharotomy is removal of the eschar in circumferential full thickness burn, and it can occur over the chest or over the limbs. This is more important. For the chest, it will compromise inspiration and expiration, but in limbs, it may compromise perfusion to the limb and make with some sort of ischemia. So we have to do urgent escharotomy in order not to compromise the chest or compromise the respiration. Okay, then what's important also here is complication of burn. Complication of burn will be general, like shock, and 3 types of shock can occur in this patient. Neurological shock from widespread pain, and this is also due to severe pain and activation of the vagus. This is a neurological shock. And also we have septic shock, and it can occur later within 1 week due to infection, and hypovolemic shock, which can occur within the 48 hours due to loss of the body plasma. These are the types of shock which can occur with burn. Also, there are some complications like acute renal failure, and this is common to occur in patients with thermal or electrical burn due to what's called rhabdomyolysis. Rhabdomyolysis with the myoglobinuria and hemoglobinuria, which can cause acute tubular necrosis. Rhabdomyolysis is also an important topic and will be discussed. And 2 important information about rhabdomyolysis you should remember: that it causes myoglobinuria, increase the myoglobin in urine, and also elevated LDH and creatinine kinase more than 2000. Myoglobinuria, release of myoglobin in urine, elevated LDH and creatinine kinase more than 2000. Okay? This is the second, which is acute renal failure. Also, acute respiratory distress syndrome, or even non-cardiogenic pulmonary edema with the refractory hypoxia. And this is more common in inhalational burn, which can cause some asphyxia and respiratory distress. And also widespread release of cytokines, which is a large peptide. What are cytokines, you know? Like platelet activating factor, tumor necrosis factor, prostaglandins, serotonin, interleukins. They can cause widespread vasodilation. Also, they can cause direct endothelial damage and alveolar edema with impaired ventilation, perfusion, scan. Okay, then also we have acute gastric dilatation, and this is commonly asked, post-burn acute gastric dilatation. Also, curling ulcer. These are peptic stress ulcers due to desquamation of the epithelium of the stomach. We have curling ulcer and Cushing ulcer. Both of them are peptic ulcers. Curling ulcer occur with burn. Cushing ulcer occur with head trauma or increased intracranial pressure. And the most important is what's called compartmental syndrome. Compartmental syndrome can occur in full thickness circumferential burn And the most important features of compartmental syndrome is pain out of proportion to the injury. Pain out of proportion to injury when doing passive movement. Also, paresthesia, tingling, numbness over the limb, and the late stage is pulseless limb, absent peripheral pulsation. Okay, I have clarified some questions about PER. Then we are going to discuss the past test questions. Please, who is ready, you can raise your hand. It will be just a discussion for all to get benefit. If no one is interested, I will read the question and read the answer. Don't worry if you answer wrong. Okay, then I'm going to select some of you to answer. When you're ready, you can raise your hands. Okay. Then I am going to read the question and try to simplify that. Okay, Dr. Noor Alam, are you ready? Can you participate? Hello, Dr. Noor.
Hello, sir.
Hello, welcome.
I'm audible.
Okay, can you read the question?
A 29 years old man is brought to the emergency department with 70% total body surface area burned, having set himself on fire in a deliberate attempt to end his life. He has life-threatening injury. Which of the following regarding the management of burn is correct? A. Endotracheal tubes should be cut to the desired position. B. Sclerotomy should not be performed until the patient is assessed in the burn unit. C. Fluid resuscitation should be commenced only after the accurate assessment of total body surface area of the burn. D. IV access should not be secured through the burned skin. E. A leathery white appearance is suggestive of full thickness burn.
Okay, then what's your answer?
So I'm confused between D and E, sir.
Okay, then what do you think? Sclerotomy should not be performed until the patient is assessed in the burn unit?
No, sir. It is an emergency procedure, sir. Sclerotomy if compartment syndrome is impending compartment syndrome is there, so we should perform sclerotomy.
Yes, you will deal with that immediately. You don't wait for more assessment of the patient and time consuming. Okay.
And fluid resuscitation is urgent because it is a life-saving, because patient is in shock, because 70% burn.
Yes. Okay,
But
then
sir,
you will go with E?
Yeah, I'll go with E, sir. Most correct option appears to be E.
Okay, right. Then the full thickness burn or the third degree burn, which is loss with the whole epidermis and the whole dermis, and also penetration onto subcutaneous and muscle. This may cause a leathery white appearance, which is suggestive of full thickness burn, and it is also desensate, no sensation. Okay, and this is right. I've chosen that. Okay, then stay for the second question. I'll share the second question now. Okay, can you read?
Yes, sir. A 27 years old man is admitted to the emergency department with extensive burn following a road traffic collision when his vehicle overturned and he was caught up in ensuing fire. There is evidence of facial burn and nasal singeing. Given that history, what is the most urgent action required? A. Commence fluid replacement immediately. High suspicion of airway inhalation. Clear airway and consult anesthetist for advice. C. Measure urine output 0.5 to 1 ml per kg per hour for adult. D. Make a secondary assessment of the burn wound accurately assessing the percentage and depth. E. Pain relief. Sir, B should be there because there is airway burn and inhalational injury is there because of nasal singeing and facial burn.
Yes, excellent. This is an airway, the most important initial step in our advanced trauma life support. We manage patient of burn and trauma according to advanced trauma life support, ETLS, and other critically ill surgical patients are managed according to CRISP protocol, care of critical ill surgical patients. Then this patient will be managed as has inhalation burn, so we will manage the patient by assessment of his airway first, and some patients also may need prophylactic intubation if they have severe laryngeal edema and bronchospasm. Okay, then B is the right answer. Excellent. Okay, then I'll send another one. Okay, that's good. Then this question.
54 years old unkempt man with insulin dependent diabetes is admitted with bilateral infected deep burn to his feet. He is suspected to have very poor glycemic control. How should his diabetes should be managed? Add in oral hypoglycemic, allow him to self-medicate, await diabetic review before deciding. D. Insulin as per normal routine. E. Sliding scale until his infection improves. So sliding scale. E should be the answer.
Okay, that's right. Sliding scale until its infection is controlled, but you should know how to manage diabetic patient pre-op. The most important here is to do strict glycemic control for the patient. So pre-operative, if the patient is with good glycemic control, even the patient in oral hypoglycemic or insulin, you should continue on it. But if the patient uncontrolled diabetes, so I will transfer the patient into sliding scale or what's called variable insulin rate infusion. It's called variable insulin rate infusion. Okay, that's right.
Okay.
And the sliding scale will be used. Okay, another question.
A 34 years old woman is admitted to the ICU with 45% total body surface area burned to her head, trunk, and perineum, having accidentally set herself on fire and a bonfire party. For which of the following complication of severe burn should you be vigilant given to this patient's injury? A. Acute appendicitis. B. Cushing ulcer. C. Myoglobinuria. D. Hypovolemia. E. Sepsis.
What do you think is the most vigilant injury which may cause to this patient? The more risky on patient is myoglobinuria or sepsis. Myoglobinuria will cause acute renal failure, and this is one organ. Sepsis will cause multi-organ failure, and this is a life-threatening. So the most important here is sepsis, not myoglobinuria. Myoglobinuria is just the kidney, but sepsis will cause multi-organ failure syndrome. Okay, this is the right answer here is sepsis. Okay, another question.
According to Wallace rule of 9, which of the following best represent the percentage burn surface area she had sustained, which would be used to calculate the amount of resuscitation fluid required? Okay, that's lead.
Okay, I will share the areas of burn. Before that, I will share, excuse me. Okay, this. Okay, can you calculate the burn area?
She has blackened insensate burn over the anterior and posterior aspect of her right arm, right upper, including her right hand and right lower limb. Okay, and there are edematous painful area without blistering over the anterior trunk. Okay, so anterior trunk is 9% and blackened over the anterior and posterior aspect of her right upper, and right lower limb. So 9 plus 9 for right upper limb and 18 for right lower limb, and 9 for right anterior abdomen. So it is 18 plus 9, 36.
36. Okay. Then anterior and posterior aspect of the right upper and right lower limbs. The upper limb is 9 and the lower
9.
limb is 18.
18.
Okay. And there is also painful areas without blistering over the anterior trunk. So, yes, excellent, Dr. Agada. First degree of burn in the trunk is not calculated. Excellent. Okay.
Okay.
Then our answer will be 36. Okay. Then this is a tricky question. Try to remember it. Okay. Then who also try to participate. Really, thanks, doctor.
Okay.
Thanks, Dr. Noor. Okay, Dr. Jeffrey.
Yes, hello.
Hello, sir.
Yes.
Okay, you have 5 questions. I'll share now. This. Okay, you can read. Okay, you see the question? Dr. Jeffrey, try to unmute yourself.
Okay. Can you hear me?
Okay, can I hear you? Okay, proceed.
All right. A 45-year-old novice mountain climber becomes trapped climbing up Ben Nevis in the winter. He is rescued but is taken to the emergency department with frostbite injuries to his hands and feet. Which one of the following statements concerning frostbite, freezing cold injury is correct? Option A, extremities affected by frostbite will require early amputation. Option B, rewarming shoulder occur rapidly to prevent superficial injury. Option C, the outcome of freezing cold injury cannot be predicted based on the degree or grade of the injury. Option D, the muscle and bone are never affected. Option E, aspirin 300 milligram should be administered to the patient suffering frostbite. From the question, I will go with option E, aspirin 300 milligram should be administered to the patient suffering frostbite.
Yes, excellent. Aspirin is taken as a prophylactic antiplatelet for all patients. We take 4 tablets. But the most important here is to remember that the patient does not require rapidly rewarming. We will also have to do gradual rewarming of the periphery in order not to cause acute ischemia for it. And the extremities are affected by frostbite will not require early amputation. We have to manage the patient conservative by aspirin and rewarming and give the patient vasodilating agent like sodium nitroprusside. Okay, then I will share another question.
Yes.
You can read that question.
Yes. All right. Can you hear me?
Yes.
Okay. A 25-year-old man presents to the Bonn outpatient clinic with excess hypertrophic scarring over his chest following a severe burn. Which of the following is a characteristics of hypertrophic scarring? A, it is characteristically seen over the extensor surfaces. B, it is characteristically extends beyond the margins of the original scar. C, it has a strong genetic predisposition. D, it is characteristically seen in deep dermal bones. E, treatment improves the appearance. I think I would go for it characteristically extends beyond the margins of the original scar. Option B.
Okay, then I will clarify to you what's the difference between hypertrophic scar and keloid. Hypertrophic scar can be seen over the flexor surface. So option E is incorrect.
Yes.
Then regarding option B, hypertrophic scar will be limited to the margin of the original scar.
Oh,
but
yeah.
keloid will extend beyond the margins of the original scar.
Oh,
Also,
yeah.
the strong genetic predisposition is more with keloid, not with hypertrophic scar.
Yes.
So option D is correct. Can be seen on deep dermal burr and on flexor surface, and also can occur in over the sternum, and this is common. Can see it. And the treatment usually improves the appearance. We can manage it conservatively by compression gel, silicone gel sheet, or intralesional steroids. Okay. Then we have it can characteristically seen in deep dermal burr. This is the correct answer. Okay. Another one. Okay, this question.
Okay, can you hear me?
Yes.
Okay. A 23-year-old man is admitted to a rural emergency department with extensive burns to his head and neck. Your consultant asks you to discuss his care with a specialized burns unit. In general burns management, which one of these is a criterion for referral? A, all forms of burns in children with suspected non-accidental injury. B, all burns in patients with no fixed abode. C, superficial burns less than 3% of the body surface area in adults group. D, all burns less than 2% of the total body surface area in patients less than or equal to 10 years. Is there option E?
Option E is some burn covering 10% of total body surface area.
Oh.
Then can you tell me when to refer patient to burn center?
My answer will be option B. What's option E again? Because none of them.
Option E is some burn covering 10% of total body surface area.
Okay, I will go with option B.
With option B, all burn in patient with no fixed abode.
Yes.
Okay, let's discuss option A, the first option. All forms of burn in children with suspected non-accidental injury. This is an indication of referral. I said it in clarification of the burn before. Any child with burn with suspected non-accidental injury should be referred to burn unit. Okay?
Oh.
Should be referred. And also any full thickness burn, any circumferential burn, any non-healed burn within 2 weeks. I will share to you now. Okay, I will share to you now this picture. Okay, it will help you slightly to read this. Okay, you see that?
Yes, yes.
According to the guidance of 2020, all patients should be referred into specialized burn care services, like all burn more than 2% of total body surface area in children or more than 3% in adults, all full thickness burn, all circumferential burn, any burn which is non-healed in 2 weeks, any burn with suspicious of non-accidental injury should be referred to the burn unit. Okay? These criteria should be remembered. Just keep them. So this is a tricky question. Another one, this question.
All right. So a 79-year-old woman attends the emergency department having collapsed onto a radiator. She has a full thickness burn to her buttocks. Which one of the following is a description of a full thickness burn? Option A, extends through the entire dermis and may have a black eschar appearance, which is painless. Involves the epidermal skin layer. is acutely painful and likely to heal within 10 days of injury. Involves the papillary dermis with associated blistering areas, blanched with pressure and are acutely painful, likely to heal within 21 days. Option D involves the reticular dermis, white in appearance, does not blanch. I cannot see the rest. I will go for option A.
Okay, excellent. Yes, full thickness burn extends through the entire epidermis, dermis, and may reach the subcutaneous tissues and the muscle and bone, and may have a black scar, and it is desensate. It is painless. Okay, then question number 10. This is your last question. Okay, this question number 10. Then this is okay.
An 18-month-old child is brought to the pediatric burn service having pulled a cup of hot coffee off the kitchen table, tipping it on himself. Which one of the following statements is characteristic of deep dermal burns? They are characterized by presence of eschar. They are more painful than superficial burns. They do not blister. They have a blotchy red coloration. They heal spontaneously by themselves within 14 days. Option A, they are characterized by presence of eschar.
Number E. Okay, and this is specific character to deep dermal burn?
Yes.
What about option D? They have a blotchy red coloration?
Oh. Deep dermal burns. Oh, yes.
Yes. Characterized by presence of eschar, deep dermal burn is a deep second degree, and eschar also occur with third degree full thickness burn. So the deep dermal burn has a blotchy red coloration. You should know the color of all of them. The first degree, which is the epidermal, is just red discoloration. Superficial second degree have blistering with erythema and moist skin. Deep dermal burn has a blotchy red discoloration. Full thickness burn has white leathery discoloration. Okay, you should remember them all. Okay, then the correct answer here, a blotchy red discoloration. Okay, thank you. Then question number 11. I want one again to participate with us. Really, thanks, Dr. Sheffield.
Thank you.
Dr. Ghada. Okay.
Okay.
Hello, Dr. Ghada.
Hello, good day.
Okay, then question number 11. Okay, can read.
Okay, I'm just waiting for the screen, yes. A 40-year-old girl is brought to the emergency department having spilled some hot tea onto herself. She has a painful burn on her right upper limb. Which of the following characteristic of superficial burn? A, it will be difficult to identify the boundaries of the burnt area. B, the burnt area will be leathery in appearance. C, the burnt area will be painful. D, the burn area will weep exudates, and E, the skin will be blistered. It's C, it will be painful because leathery is for full thickness burn, and it will be identified for the boundaries. It will be so obvious. The exudate, I think, is for second degree superficial thickness, and the skin will be blistered also in the second degree. So it's painful. C.
Excellent, doctor. Then the correct answer will be the burnt area will be painful.
Will be painful.
Okay, then another question. Okay.
Okay. A 27-year-old man is admitted to a burn center with 30% full thickness burns after a self-immolation injury. He arrives approximately 1 hour after the injury and his body weight is estimated at 70 kg. He has not received any IV fluid yet. how much fluid you should receive after the next 7 hours, and use the ATLS 10th edition formula. Okay, his weight is 70, and the percentage is 30%. It's more than 20%. So half Parkland formula will be used. Multiply the weight 70 by 30 by 2.
Yes.
And then 70 by 30 is 2,100 by 2 is 4. And then we divided, sorry, we divided by 2, and for the first 8 hours, 30 by 70. I think this 100 C option will be most accurate. I think I don't have a pen and paper to calculate.
Okay, this is
But
simple. The body weight
okay,
is
it's
70.
70.
70 multiplied by 30%.
By 30%, and then by
2,100.
And 100, yes.
Then by 2 will be
By 2,
4,200.
for 200, yes.
But in the first
And
8 hours,
half,
I will give half of the dose. Okay, then
half
your
the
answer will
amount.
be?
So I think D, 2,100, yes, D.
Yes, excellent. This is simple. But here, he asked you to use the ATLS 10 edition formula, not Parkland formula. Parkland formula, I will multiply by 4, but the ATLS 10th edition formula will be multiplied by 2. Okay,
by
remember
2.
that always.
Yes, by 2.
Okay, another question. Okay.
A 1-year-old child is rushed to hospital having reached over a coffee table, spilling a cup of freshly made tea over herself. She is accompanied by her parents, who give a consistent and reasonable history. When looking after this child, which one of the following actions or indications is correct? A. Urine output of 0.5 ml per kg per hour is an indicator of adequate hydration. B. Dark lobster red with a slight mottling is indicative of deep, partial, or full thickness burn. C. Inotropes may be required in burn more than 5% of the body surface area. D. The rule of nines accurately estimate the percentage of burns. Okay, the first one is not adequate for her age. Must be more than 0.5 ml per kg per hour for her urine output. And inotropes, I have no idea. So either B or D, because E is not obvious here.
Okay, let's
bluster.
discuss everyone. Okay, the first is urine output of half milliliter per kg per hour. Okay, from half milliliter to 1.
Age.
Okay, for adults,
this is for adults.
Optimal.
This is for adults.
Yes, excellent. For adults, the most optimal is half to 1 milliliter.
To
for
1.
children, from 1 to 2. And this is a
1
child.
to 2.
Okay, this is an not adequate urine output for this patient. This patient is oliguric. Okay, then option B, a dark lobster red with a slight mottling is indicative of deep burn or full thickness burn. This is right. Dark
this
lobster,
is right,
or
because it's lobster red.
Okay, this is right.
Deep redness, yes, this is right.
Okay, then inotropes, as you see, have no rule, and the rule of 9 not used for children. Well,
for children, there's a modified table. Yes.
Load and the Browder. Load and the Browder chart. Okay.
Load and Browder. Yeah.
Then the right option here is a dark lobster red or blotchy red, as the previous question, with a slight mottling is an indicative of deep partial burn or full thickness burn. Okay.
Full thickness burn. Yes.
Another question. Read this question.
Okay. A 22-year-old man is undergoing treatment for a burn sustained during a lightning strike. He has a clear entry and exit area of injury. Which one of the following statements concerning electrical burn is correct? A urinary output of 15 ml per hour should be aimed for adult with myoglobinuria secondary to electrical burn. B. All patients with electrical burn require cardiac monitoring for at least 24 hours. C. High voltage injuries lead to metabolic alkalosis. D. Low voltage injuries do not cause full thickness burn. E. Renal failure is a recognized complication of electrical burn. Well, the first option, urine output must be 100 ml per hour. The
Yes.
second one, okay, in previous literature, there will be a need for cardiac monitoring, but I don't remember for how long. And the high voltage injury leads to metabolic acidosis, not metabolic alkalosis, and there will be tissue damage and hemolysis and hyperkalemia. Low voltage injury do not cause full thickness burn. It's not about the voltage, it's about the current. So there will be full thickness burn as usual. But renal failure is a recognized complication. That's true because of tissue hemolysis. So there will be a renal failure. So I choose E.
Yes, as you told, the myoglobinuria and the rhabdomyolysis will cause acute tubular necrosis and acute renal failure. Yes, this is right. Okay, then question number 15. You are excellent, doctor.
Thank you.
Okay, question number 15. Okay, 25.
A 25-year-old man sustains a circumferential burns of one of his arms after falling into a campfire. On initial assessment, he appears fairly well, and the A&E team are considering discharging him. What's the most important thing to monitor in this patient? A. Blood gas to check PO2, B. Blood pressure, C. Oxygen saturation, D. Myoglobinemia and myoglobinuria, E. Peripheral pulses and capillary refill. Everything is important, but we are looking for the most important. Well, he's quietly good. Okay, circumferential burn, compartment syndrome, D. Myoglobinemia and myoglobinuria.
Okay, but myoglobinuria and myoglobinemia also monitored in all types of burn. Why he mentioned the circumferential burn in the arm?
Circumferential, it means there will be a compartment syndrome because it's a closed space of muscle.
Yes,
and
then I will monitor
all around. Yeah.
All around, yes, but to prevent limb loosening, I will monitor the peripheral pulse and the capillary refill.
I thought about them, yes, but when I saw circumferential, it changed my mind. It's either myoglobinemia or because it's a type of crash injury, or peripheral pulse and capillary refill. But if there is circumferential pain and we thought about compartment syndrome, there will be the pain on a passive stretch or something like that. Okay.
But every question will be specific words for a specific answer. Circumferential burn and arm. So I will go also for peripheral pulse and the capillary refill.
Okay.
What is a normal capillary refill?
It's within 1 to 2 seconds.
1 to 3 seconds. Okay. Okay, excellent.
Yes.
Another question. Or this is your last question? Okay, another one.
I think this is the last one. Yes.
Okay, another one. Okay. Thanks, Dr. Ghada.
You're welcome.
Okay, anyone want to participate? Dr. Jeffrey again. Okay, I'm going to select persons who want to participate. Also, Dr. Khan, Dr. Salma, Dr. Benson, Dr. Sharif, Dr. Khan. Okay, then Dr. Khan. Okay, ask to unmute. Welcome, doctor.
Yes, sir. Can you hear me?
Yes. Okay, I will share the next question for you. Okay, this is an important question.
A 5-month-old child is admitted from home with fever, rash, malaise, and 3-day-old partial thickness burn to her right hand. Which one of the following options is the working diagnosis? Bronchitis, cellulitis, meningitis, toxic shock syndrome, viral infection.
Okay, what's your answer?
Partial thickness burn. I think my answer is toxic shock syndrome.
Okay, excellent. Toxic shock syndrome, which is caused by Staphylococcus aureus organism.
Yes.
And this is some sort of sepsis characterized by triad, fever and rash and tachycardia. Fever, rash, tachycardia. Any
Rash,
post-burn
tachycardia.
patient with a triad of fever, rash, tachycardia, you should suspect infection of toxic shock syndrome. Okay, this is an important question. Another one. Okay, can you hear me, Dr. Khan?
Yes, I can hear you.
Hello, okay, let's proceed.
Yes. A 28 years old man presents to the emergency department with thermal injuries to his right palm after a gas explosion. He has painful blisters and circumferential area on the right forearm that is non-tender and white in appearance, plus burn to his face. Glasgow coma score is 15, airway is patent and respiratory function is unaffected, but there is no soot in his nostrils. Which one is the best definitive management for this patient? Admit to surgical ward for observation, clean wounds and apply dressing, intravenous fluid replacement, reassure and discharge, refer to burn unit. As there is no sign of soot in his nostril, there is no.
What do you think?
I think this patient need to admit in surgical ward for observation because patient has thermal injury in his right palm and there is blister and circumferential area. Patient may develop compartment syndrome or any other complication. That's why. And there
What
is
is the
no
most
sign
important
of,
for this patient? The most important, according to advanced trauma life support, is his airway. So
yes,
you
airway
have,
is no sign of
yes, there is
patent and
soot
respiratory
in his
function is
nostril.
unaffected. Yes.
So what is the meaning of soot in his nostril? Means that there is some sort of
Airway
inhalational burn.
injury, inhalational burn, yes, sir.
So this is an
But patient
indication
has
of refer to
circumferential
peritoneal.
area of his right forearm burn.
Okay,
That's why
these
I
are
think.
the other areas of burn. But once there is a soot in his nostril, this is an indication of refer to the burn unit due to inhalational injury. Okay,
Yes.
can you tell me what are the indication of referral to specialized burn unit?
Any burn in more than 3% surface area in case of adult and 2% surface area in case of child, or any burn involving the face in the perineal region, or any vitals or involving inhalational sign of injury. In case we need to refer higher center.
Okay, for adults, the indication of referral to specialized burn unit will be full thickness burn greater than 5% of total body surface area, any electrical or significant chemical burn, inhalational burn, they are
Yes,
indication of referral. Also partial thickness more than 10%, or
yes,
partial thickness more than 20 in other age group between 10 to 50 years old. Okay, I will send to you at the group to see it. Okay, then another question. Refer to burn unit, then this question. Okay. Okay, proceed.
yes, sir. A 43-year-old woman suffered a scald into her trunk after her hot water bottle burst overnight. Examination reveals a tense blister in left upper quadrant with a surrounding area where it appears other blisters have continuously burst. The area has a capillary refill of 2 seconds and is tender to touch. The total area is equivalent to twice the size of his patient's palm. What is the estimated size of the burn? We consider our palm is a 1%. That's why I think this is a option C is correct, 2%.
Yes, excellent. Palm is 1%, so it is twice the size of the patient palm. It is 2%. Right.
Yes.
Another one. Okay. This question.
Yes, sir. A 70 kg woman receives approximately 20% full thickness burn in a house fire to her chest, abdomen, and left arm circumferentially. How much fluid does she require over initial 24 hours? Here, total percentage 27% full thickness burn. 27 into body weight 70 kg. According to ATLS guidelines, sir.
Yes, yes, according to ATLS.
35 into 27.
Okay, then 27 by 70 is
27 into 35.
Yes, 1,890. Then you will multiply by 2. It will give you 3,780.
3,780 ml, option D.
Yes, this is option D. Okay. Just you have the principle and you can calculate it. Okay. So option D is right. Another question. Okay, and this is an important question.
Yes, sir. A 32-year-old man attends the emergency department having sustained a chemical burn to the back of his hand from an unknown substance. Which one of the following statements regarding chemical burns is correct? Acid causes more damage to the deeper tissue than the alkali burn. Alkali burn are more painful than acid burn. Dry powder should be immediately irrigated with copious amount of water. Neutralizing agents should be the first line of treatment in cement burn. Systemic calcium may be required in the treatment of burn due to hydrofluoric acid. Sir, systemic calcium may be required. I will go for E.
Excellent. The relation between calcium and hydrofluoric acid is important
Yes,
to be discussed in burn. Usually hydrofluoric acid causing hypocalcemia. And I have clarified that in the discussion before, that acids
yes,
causing more pain, not more deeper damage. But alkali cause more deeper damage, not more pain. So
yes,
option A and B are wrong. Then the dry powder should not irrigated with water, should be skipped away, then to pre-irrigate your hand or your arm, then the neutralizing agent not used as a first line of treatment because the neutralizing agents cause some heat and more tissue damage. So all options are wrong except A, which is right. The relation between calcium and hydrofluoric acid is also important. Hydrofluoric acid causing hypocalcemia. Okay,
yes, sir.
this is your last question. Thank you, Dr. Al-Khan. Anyone also want to participate? Okay, please raise your hand. Okay, anyone? Dr. Jeffrey Al-Khan, Dr. Aida, Dr. Ahmed. Okay, anyone wants to participate? Okay, then I'll repeat again with Dr. Jeffrey. Another question. Okay. Who's ready? Dr. Jeffrey, Dr. Aida, Dr. Al-Khan, if you want to complete. Dr. Aida,
Hello.
okay?
Hello.
Yes, sir.
Okay, who wants to complete?
Okay. Can you hear me?
Okay, Jeffrey.
Okay. All right. So a 34-year-old woman is admitted to the intensive care unit with 45% total body surface area burns, having set herself on fire. She requires invasive monitoring in the initial phase of her recovery. Which one of the following gastrointestinal disturbances would you expect to find as a result of her injury? A, acute gastric dilatation. B, Cushing's ulcer. C, increased gastric acid production. D, splanchnic vasodilatation. E, terminal ileal lymph node hyperplasia. Option A should be correct, acute gastric dilatation. Option B, Cushing's ulcer would not be seen in bones, it will be Collins ulcer. Cushing's ulcer will be seen in any other thing, any head injury or
Head trauma, yes.
or trauma. Option C,
Yes.
increased gastric acid production is seen in normal peptic ulcer disease. Option D is splanchnic vasodilatation. I'm not so sure. Option E, terminal ileal lymphoid hyperplasia. I am not so sure about that as well. So my answer will be option A.
Okay, as I told previously, that's complication of burn or shock. And regarding GIT will be acute gastric dilatation, which is called Mendelssohn syndrome, and curling ulcer, not Cushing ulcer, because Cushing
Yes.
ulcer occurs with head trauma. Okay, then decreased gastric acid production, and it is not time for increased gastric acid production in this stress. So there is a decreased gastric acid production. Also, I have to increase the blood to the brain and the heart in the expense of the skin and splanchnic area. So due to, like Dr. Noor Alam says, yes, there is a sympathetic overactivity. So there is a splanchnic vasoconstriction, not a vasodilation. So the correct answer will be acute gastric dilatation, Mendelssohn syndrome. Yes, excellent. Question number 22. Go on.
A 60 kg man suffers 20% burns. He is referred to the regional burn center. What is the estimated volume of intravenous fluid replacement that should be administered in the first 8 hours from the time of the burn using the ATLS 10th edition formula? That will be 60 multiplied by 20, which is 1,200 multiplied by 2. That should be 2,400 divided by 2, which should divided by,
Yes.
sorry.
By 2
divided,
years?
Yes, which should be 1,200. So
Yes.
option C, given the first 8
Excellent.
hours. Yeah, and the next in the 16 hours, yes.
Okay, fluid resuscitation for burn patients will start it at the site of the burn, immediately at the site of the burn. I will give the patient crystalloids like Hartmann or Ringer lactate. I will go with 2 formulas, Parkland Formula or Advanced Trauma Life Support 10th edition formula. And the pastist loves the ATLS 10th edition formula. Okay, then I will give half of the dose in the first 8 hours, and the another half will be in the last 16 hours. Okay, then another question.
Okay. A 36-year-old man is admitted to the ICU having sustained 60% total body surface area burns. The team are having some difficulty optimizing his fluid balance. What is the single best method of monitoring his fluid requirements? A, blood pressure. B, heart rate. C, capillary flow. D, temperature. E, urinary output. Option E is urinary output. That's the correct answer.
Yes, excellent. Then tell me what's the normal urine output for an adult and a child?
For an adult, it is supposed to be greater than 0.5 to 1 ml per kg per hour, and for adults is for children 1 to 2 ml per hour.
Yes, excellent.
Yes.
For adult, half to 1 milliliter per kg per hour. For
Yes.
children, 1 to 2 milliliter per kg per hour. Okay, excellent.
Yes.
But I monitor the patient with all of this: capillary refill, peripheral temperature, heart rate, blood pressure, and urine output. But the most important to monitor the patient response to crystalloids is urine output, and also the central venous pressure by the CVP.
Yes.
Okay. Another question. Okay, go on.
A 23-year-old man is admitted to the intensive care unit with 60% burns. He remains very unstable for a few days, requiring central line and arterial line access. Which one of the following is a systemic effect of his type of trauma? Option A, glycogenesis. Option B, hypovolemia. Option C, hypothermia. Option D, immunosuppression. Option E, reduced metabolic rates, I will choose immunosuppression. Hypovolemia, option A, glycogenesis, usually does not occur following trauma. It's usually gluconeogenesis. Option B, hypovolemia, usually not so. It's usually hypovolemia. Option C, I'm not so sure which one of them, either hypothermia or immunosuppression. I'm quite confused around there. And option E, it's going to be increased metabolic rate.
Yes. Then you will go with C or D. The most likely to occur
I'll go
is
with D. I will go with D, immunosuppression.
Excellent, excellent. Immunosuppression. This is a stress response of the body to burn or to trauma.
Yes.
There is no time to store glycogen, so no glycogenesis. The incidence which can occur is the glycogenolysis and gluconeogenesis. And the patient has some plasma loss, so there is hypovolemia due to release of the cytokines and tumor necrosis factor and the cachexin, which play an important role in the perivascular area of the hypothalamus, so they can elevate the temperature of the patient and causing hyperthermia. And immunosuppression due to loss of the skin barrier, which protects the patient from outside pathogens, so the immunosuppression is more likely to occur. Okay, this is an important. And this is a stress response, so there is an increased metabolic rate. So the correct answer is D. This is an important question also. Immunosuppression following trauma. Another one. Okay. This question.
Okay. A 17-year-old girl is seen in the adult burns unit having sustained 8% total body surface area burns with sunbathing. She has quite severe pain, but is otherwise well. Considering epidermal burns, which one of the following can be applied? A, they are associated with a normal capillary refill time. B, they are characterized by blistering. C, they are not usually painful. D, they heal by primary intention. E, they often require surgical excision to prevent scarring. The option is D, but I'll go through all of them. They are associated with a normal capillary refill time. Okay, I'm not so sure. B, they are characterized by blistering. No. C, they are not usually painful. They are painful, so that is wrong. D, they heal by primary intention. I think so. And E, they often require surgical excision to prevent scarring. No, that is false. That will go for full thickness bone or deep dermal bones.
Yes. So you have debate between A and D.
Yes.
Tell me what are the ones which heal by primary intention?
Sorry, I didn't get that.
Wounds which heal by primary intention. They are the clean surgical wounds. Like at operation, you open the skin, then you suture it, and it heals by primary intention. This is a clean surgical wound, which can heal by primary intention.
Yes.
Okay? This is a primary intention. But all burn can heal by secondary intention. Repeated dressing and follow-up, this is a secondary intention. Okay? But in superficial epidermal burn, this is a first degree burn. So there is a normal capillary refill time, which is from 1 to 3 seconds. This is the correct answer. Okay, and as you see, blistering in the superficial second degree. And it is usually painful due to exposure of the nerve endings and does not require surgical excision.
Yes.
Okay. Okay, excellent. This is a correct answer is A, associated with normal capillary refill. Okay, question number 26. Okay, go on.
Okay. So a 12-year-old boy is admitted to the hospital having sustained burns covering the wall of the back and front of his trunk after he was set lightly accidentally by friends. There is a mixture of superficial and full thickness burns present. Which one of the following is correct regarding the treatment of burns victims? Fluid resuscitations with dextrosaline, that is false. It's with Hartmann solution. B, full thickness burns are extremely painful. That is false. They are not painful. C, his treatment should be based on an estimated burn area greater than 30%. Yes, That is correct. Patient should have a bladder catheterization. That is also correct. E, secondary infection is most likely to be streptococcus. No, false, with staphylococcus. D, for urinary output monitoring, yes, correct. For the estimated bone area, I'm not sure of the percentage now. I think it's 30%, but I'm not sure.
Okay, try to calculate it, covering superficial burn or deep burn, full thickness, and superficial burn to the whole back and the front of the trunk. Okay, then the percentage will be
18%.
18% for the front and 18% for the back.
No, 9% for the front and 9% for the back.
Okay, then this is not greater than 30. Okay.
Yes.
Then I will monitor the patient in order not to do acute tubular necrosis or acute renal failure and hemoglobinuria or myoglobinuria and obstruct the tubules. So I have to monitor the patient by bladder catheterization. I will give the patient IV fluids and should monitor the patient by urine output through a bladder catheter.
Yes.
Okay. The most important for this patient is the urine output, which can be monitored by bladder catheterization. Okay. Another question. Correct answer here is D, bladder catheterization. Question number. Okay. This question. We discussed it before, but I think it will be simple for you. Okay, go. Hello, Dr. Jeffrey. Hello, do you hear me? Okay, Dr. Khan, Dr. Ghada, if you are ready.
Okay.
Hello. Yes, sir. Okay, carry on.
Okay. A 47-year-old factory worker is referred to the burn center following a suspected chemical burn in his workplace. It's noted that he has erythema and blistering of both hands, and further history from the workplace reveals that the burn is likely to be the result of hydrofluoric acid. Which one of the following ions can become intravascularly depleted as a result of this? It's calcium.
Yes, we remember that hydrofluoric acid causing calcium depletion and hypocalcemia. This is an important relation only in bus test. This question only in bus test, not in MRCS at all. Okay, another question.
A 29-year-old man is admitted to hospital having sustained 35% total body surface area burns in a house fire. There are no obvious signs of inhalation injury. His breathing and airway seem okay. Which one of the following is recommended regarding the initial management of burns? A, application of silver sulfadiazine is recommended before the patient is transferred to the burn unit. B, clothing should not be removed immediately as it tears away burn skin. C, full thickness of burn more than 5% of the body surface area is an indication for transfer to the specialized burn unit. A and B both wrong.
Yes.
And
I'll
C,
share
it's
all options.
okay. Just to make sure for the other options. Okay, D, ice or very cold water should be used for 20 minutes to cool the burn. This is not true. E, nasogastric tube should be avoided in the early stage as they predispose to gastric ulcer. This is advice. It's the opposite thing because it's protective against curling ulcer and acute gastric dilatation. So it's C, because he's adult and more than 5%, it's needing a special care in burn unit. So C,
yes.
It's right.
Yes, excellent. Full thickness burn of more than 5% of the total body surface area is an indication to transfer patient to specialized burn unit. Okay, excellent.
Okay.
Then I will share some questions for burn also collected from outside like that.
Okay.
assessment of burn area, the percentage for one. There are 4 questions and you have to select from above.
Okay. First one, a 24-year-old man is rescued from a house fire and suffered extensive partial thickness burns to the whole of his back and posterior aspect of both legs. Okay, the whole of his back, it's 18%, and posterior aspect of each leg, it's 9%, so both legs, it's 18, so it's 36% must be, so it's D.
Option
16,
D.
D.
Okay, excellent, right.
Should I complete?
Okay, continue, another question.
Yes. A 16-year-old male suffers partial thickness burn to his palm of his right hand. It's only 1%. J.
J. Okay, excellent.
Right. An 8-year-old girl pours a kettle of boiling water over herself, suffering full thickness burn to her anterior trunk. Anterior, it's 18%. F. But she is a child, I'm not sure.
Yes, she will go with F. F, yes, excellent.
Yes, okay, okay. A 64-year-old engineer is involved in a major gas explosion, suffering full thickness burn over the head and neck, and partial thickness burns to chest, abdomen, and arm. Okay, head and neck, it means the whole head and neck, it's 9%. And
yes.
There's partial thickness, chest also 9, this is 18. Abdomen, 9%. Abdomen is not the half of the trunk, so also 9, this is 27. And arms, 9. Arm, it means both anterior and posterior, right?
Yes.
Okay, both arms, so 18 with 27, 35% means 36%, 45, okay.
45,
5 areas.
yes. Yes.
Yes, 5 areas. Both
That's
arms.
good. Then B
Yes.
is the answer. Okay.
B.
Excellent. Okay, thank you, Dr. Ghada. Who wants also to participate? Last slide. Complication of burn. This is an important slide. Okay, who wants to participate? Dr. El Khan, if you want to participate, you can proceed.
Yes, sir. A 45-year-old woman is brought to accident and emergency after being rescued from a house fire. On examination, she has suffered partial thickness burn to both arm and full thickness burn to her chest and the sole of her feet. She distressed and coughed upsuit as she asked to see her family. Respiratory rate is 33 per minute with poor chest expansion. Pulse oximetry is 94%, 15-liter oxygen through non-breath mask. Auscultation of the chest reveals a poor air entry bilaterally with no added sound. I think patient may develop compartment syndrome. That's why patient can breathe. There is a full thickness burn in his chest.
Full thickness burn to his chest will compromise inspiration and expiration.
Yes.
The patient will not take complete inspiration. So the patient will has hypoxia.
Yes,
okay.
Sir.
Then low PO2 will cause stimulation of the peripheral chemoreceptors, which can cause increase to the respiratory rate. So the patient will also has tachypnea.
Yes.
Okay.
Patient here respiratory rate is 33.
But due to incomplete inspiration of the patient also will retain CO2. So the patient will has hypoxia and hypercapnia. So this is type 2 respiratory failure. Type 1 is only hypoxia. Type 2 is hypoxia and hypercapnia.
With
and the impatient with eschar at the chest, the patient always has type 2 respiratory failure. You should keep it. Full thickness to the chest, which need eschar, cause type 2 respiratory failure, hypoxia, and hypercapnia. Okay? Question number 2.
A 35-year-old man is being monitored on the burn up unit after suffering full thickness burn to his hands secondary to high voltage electrocution. Urine analysis reveals microscopic hematuria. Blood test reveal a mild hyperkalemia and a creatinine kinase is of 3000. It is so high. In hyperkalemia,
Okay, this syndrome is called
hypothermia, treatment thrombosis, contracture, hypovolemia. So I can patient may develop urine complication, marketing
I said before, this is a syndrome which is called crush syndrome, rhabdomyolysis,
Yes, sir.
which can
Yes, sir.
cause myoglobinuria and hemoglobinuria,
Sorry, I can't find
hyperkalemia.
this option. Sorry.
Yes, hyperkalemia, hypocalcemia, and the creatinine kinase more than 2000. I say
Yes, sir.
it. I say that before. You will return back to the recording. You will hear it. Okay. Then this is what's called crush syndrome, rhabdomyolysis. This is myoglobinuria, hemoglobinuria,
Yes.
hyperkalemia, hypocalcemia, elevated LDH, and elevated creatinine kinase more than 2000. Okay. Then question number
Yes, sir.
3.
A 2-year-old child is brought to accident in emergency, acutely unwell by her mother 48 hours after suffering a scald to the right forearm. On examination, there is a flamazine dressing over the burn site. The patient is pyrexial and tachycardic with a low blood pressure.
This syndrome, I said it before.
Yes, sir. Toxic shock syndrome.
Yes, triad of toxic shock syndrome, post-burn toxic
Yes,
shock
sir.
syndrome, fever, rash, tachycardia.
There's
This
tachycardia.
patient
Yes,
has fever, pyrexia, and tachycardia. And this post-burn,
Yes,
this is toxic shock syndrome, and this is important to be discussed. Okay, question number 4.
A 47-year-old man with a full thickness circumferential burn to the left arm complains of persistent pain refractory to morphine analgesia. On examination, radial and brachial pulses are palpable. The arm is too painful to examine.
Easy one. Circumferential burn to arm, to
Circumferential burn.
limb. Cause?
Yes, sir. These patients develop the complication due to compartment syndrome. L.
Excellent, excellent. Compartmental syndrome. What are the criteria of compartmental syndrome? Pain out of proportion to type of injury on passive movement. Then when you tell
Yes,
the
sir.
patient to extend his arm or to move his fingers, there will be severe pain due to the scar which is found in his arm. Also, paresthesia, tingling, numbness over his arm. And the late sign is absent pulse, pulseless limb,
Pulse,
and this
yes,
is delayed. Okay, we have finished
Yes,
per. I think we have no time for shock. It will take also the same time. We have about 2 hours from now. Okay, I think of, do you want to complete or postpone shock to the next session, Friday?
sir. We can complete.
Okay,
I don't know
okay.
other members.
Other members, what do you think? Can complete or not? I will stop recording initially. Now I'm going to discuss shock. If you want a break for about 5 minutes or 10 minutes, just tell me, okay? Can give you a break now. Okay, then I'll continue.
Okay.
I'm going to clarify the shock from our notes. Okay, this is shock. Now I'm going to explain shock. What's the definition of shock? Shock is an acute, life-threatening condition characterized by diffuse cellular and tissue hypoxia with insufficient tissue perfusion to the degree that cannot meet the body metabolic needs. So we have a lot of types of shock. The most important to be discussed in MRCS are hypovolemic and septic shock, but there are other types. like distributive shock, and distributive shock have 4 types. They are collected in the word SANA, S-A-N-A: septic, endocrinal, neurogenic, anaphylactic. Okay, this is the word collected in the word which is called SANA. SANA. This is the septic, endocrinal, neurogenic, anaphylactic. This is the distributive shock. Okay, then I am going to clarify each one separately. Hypovolemic shock, which may be caused by hemorrhagic and non-hemorrhagic shock. Hemorrhagic due to blood loss, either intraoperative or with trauma. Non-hemorrhagic shock due to loss in severe diarrhea or surgery spacing like pancreatitis. And hypovolemic shock characterized by the body response to it will be to maintain effective circulatory volume. What's the body response to maintain effective circulatory volume? The initial response will be neurological, and the delayed response will be endocrinal. Stress response to any hemorrhage or any hypovolemia will be neurological factors and endocrinal factors. Neurological factors, which are called also sympathoadrenal factor. Sympathoadrenal factor due to stimulation of the arterial baroreceptors. Do you know where are the arterial baroreceptors? They are localized in the aorta and the carotid sinus. Supplied by aorta by vagus, carotid sinus by the glossopharyngeal nerve, cranial nerves 9 and 10. Then stimulation of the arterial baroreceptor will be decreased due to hypovolemia. Decreased stimulation of them. Okay, due to decreased the normal inhibitory impulse of these nerves on the vasomotor center. Then stimulation of the sympathetic nervous system causing constriction of artery and vein. Constriction of artery to increase the peripheral vascular resistance. So in patients with hemorrhage, there is an increased peripheral vascular resistance due to 2 causes: sympathoadrenal response, or increased the sympathetic overtone due to vasomotor center activity, and also due to endocrinal response, release of catecholamine, which act on the alpha receptors. So there is a constriction of artery, also increase the constriction of veins, as normally veins contain about 2/3 of the blood volume. You should know that veins contain about 2/3 of the blood volume. Okay. Then the endocrinal response will be in the form of catecholamine release. Catecholamine play an important role in stimulation of alpha and beta receptors. Alpha receptor will cause vasoconstriction. Beta receptor on the heart will cause tachycardia, increase the cardiac contractility and heart rate, chronotropic and inotropic. Also release of some stress hormones like cortisol, glucagon, growth hormone, ACTH. Also release of the antidiuretic hormone, especially when blood loss is more than 10%. Antidiuretic hormone. What is the action of antidiuretic hormone? It can cause reabsorption of water through insertion of aquaporine 2 channel. Aquaporine 2. They are inserted into the luminal border of the distal convoluted tubule and collecting duct to reabsorb water, and causing solute-free water retention. Solute-free water retention and oliguria. The other name of the antidiuretic hormone is vasopressin. Then another important hormone to be released on hypovolemia is the renin, which is secreted from the juxtaglomerular cells, which are found in the media of afferent arteriole. Renin causing stimulation or activation of angiotensinogen into angiotensin 1. Then angiotensin 1 is converted by angiotensin converting enzyme, which is found in the lung, into angiotensin 2. Angiotensin 2 cause vasoconstriction within 20 minutes after the hypovolemia. Vasoconstriction within 20 minutes after the hypovolemia. And also release of the aldosterone after the angiotensin, which can cause salt and water retention and hypervolemia. Okay, this is the response of body to hypovolemic shock. Now, I will discuss the septic shock. Septic shock, the most important organism to cause septic shock is gram-negative bacilli. Gram-negative bacilli. Gram-negative bacilli cause release of material which is called the endotoxin. Endotoxin is the lipopolysaccharide of the membrane of the gram-negative bacilli. So septic shock is also called endotoxic shock. Septic shock is called endotoxic shock, while hypovolemic shock is called oligemic shock. So septic shock, release of the lipopolysaccharide of the gram-negative bacilli, causing release of the endotoxin, endotoxin causing destruction of the lysosomal membrane, and release of cytokines. Cytokines like I said before, tumor necrosis factor, platelet activating factor, serotonin, prostaglandins, and this causes endothelial damage and alveolar damage. So the most important in this patient of septic shock will be hypovolemia, but due to widespread vasodilation, they will increase the venous return and increase the cardiac output. So there is an increased cardiac output. And you should remember that all types of distributive shock, I remember them in the word which is called SENA, septic, endocrine, neurological, neurogenic, and anaphylactic. Most of them have decreased systemic vascular resistance. All distributive shock types have decreased systemic vascular resistance. I collected them in the slides I will share for you now. This is an important slide. Okay. Okay, I will share this. This is an important. Shock types and their physiology. Hypovolemic shock, due to blood loss, there will be decreased CVP. And the cardiac output due to blood loss will decrease the venous return and decrease the stroke volume and hence decrease the cardiac output. But due to sympathoadrenal response and the release of catecholamine, there will be decreased the peripheral vascular resistance. So hypovolemia finished. Then septic shock, there will be decreased central venous pressure due to widespread vasodilatation. Okay, then increased cardiac output. Here we have to put a question mark here because septic shock has two phases of septic shock. The first phase is warm or hyperdynamic phase, then the hypodynamic or cold phase. In the hyperdynamic phase, there is tachycardia, hyperthermia, and increase the cardiac output. But later on, if the shock became irreversible, it's the hypodynamic and the cold phase, and there is a decreased cardiac output. But as I told you, in all distributive shocks, there is decreased the peripheral vascular resistance, which will decrease here. Okay, then it will decrease here. You see that, like in septic and neurogenic and endocrinal and anaphylactic. All of them are decreased. Here will decrease, here will decrease, here will decrease. All types of distributive shock, septic, endocrine, neurogenic, and anaphylactic shock. Okay, then I will remove that. This is an important slide for you all. You should know this. Okay, I will share again. Then neurogenic shock, which occur after spinal cord transection with sudden decreased sympathetic tone, will cause bradycardia and hypotension and decrease the peripheral vascular resistance. Remember, in neurogenic shock, all are decreased. Hypotension, decreased sympathetic tone, decreased sympathetic tone, hypotension, bradycardia, and decrease the peripheral vascular resistance. All are decreased in neurogenic shock. Then cardiogenic shock, which can occur, the most common cause of cardiogenic shock is acute MI, is acute myocardial infarction. And this is the Obstructive shock. Some types of the obstructive shock are cardiogenic shock and obstructive shock like cardiac tamponade or tension pneumothorax. All of them characterized by increased central venous pressure, CVP, with decreased cardiac output due to pump failure. Cardiogenic shock have decreased cardiac output due to pump failure. Okay, this is the most important here. Then now I'm going to discuss past test questions. This is also some share of the systemic inflammatory response syndrome. What is SIRS? SIRS is a global inflammatory state characterized by a set of symptoms and findings which are found before sepsis. Two criteria of these four can indicate systemic inflammatory response syndrome, like temperature more than 38 or less than 36, heart rate more than 90, tachypnea with respiratory rate more than 20, and TLC more than 12 or less than 4. Okay, then two criteria can diagnose systemic inflammatory response syndrome. With infection, it became sepsis. With organ dysfunction, it became severe sepsis. Add over them hypotension, it will become septic shock. Okay, then this is the body response to hypovolemia. As I told you, within seconds, the neurological factors start, then the endocrinal factors, which can take some minutes to hours. Due to decreased stimulation of the arterial baroreceptor, which are found in the aortic and the carotid sinus, and decreased stimulation of the arterial stretch receptors, both of them are supplied by vagus and glossopharyngeal, causing constriction of artery and vein. Constriction of artery increases the peripheral vascular resistance. Constriction of vein will shift the blood to the heart, because veins contain about 2/3 of the blood volume. Okay, then let's discuss our questions. Who is ready to share with me questions? Before I start the questions, I have the classification of hypovolemic shock. This is extremely important for all of you to remember. Class 1, up to 750 milli blood loss, from 750 to 1050 to 1500, then 1500 to 2000, and then more than 2000 milli blood loss. Then the blood volume 15%, then 15 to 30, 30 to 40, more than 40. Heart rate less than 100, from 100 to 120, 120 to 140, then more than 140. It is important to remember that blood pressure started to decrease in class 3 only, in class 3 and 4. Okay, class 1 and 2, normal blood pressure. So blood pressure started to decrease in class 3. Heart rate started to increase in class 2. Okay, then tachypnea became to occur also in class 2, and urinary output became to decrease from the start, less than 30s and 20 to 30s and 5 to 15, then negligible. And the mental status, I remember it from ACL, anterior cruciate ligament, ACL. ACL is anxious, confused, lethargic. Anxious, confused, lethargic. Okay, then start the questions. Who wants to participate, please raise your hand. Okay, Dr. Ghada. Dr. Ghada, nice. Okay. Let's start.
A 75-year-old man has suffered acute loss of 25% of his blood volume. He has a pulse rate of 110 per minute, a respiratory rate of 25 per minute, and a urine output of 25 ml per hour. Which class of hemorrhagic shock most appropriately describe this patient? Class 1 hemorrhagic shock, class 2, class 3, class 4, or none of the above. 25%, and he has tachycardia. Class 2, it's more than 100 pulse rate, but less than 120. Class 2, hemorrhagic shock.
Yes,
due to
excellent.
hypovolemia.
Yes, pulse rate from 100 to 120. This is a class 2. Okay.
Okay.
Another question. This one.
You attend a trauma call to a 25-year-old patient who has a liver laceration and is in class 3 hemorrhagic shock. There is free fluid in MRCS on a fast scan. What physiological effect would hemorrhagic mismatch be? Decreased arterial pressure and subsequent reduction in antidiuretic hormone secretion. C, increased catecholamine secretion by adrenal cortex. D, increased tidal ventilation. And E, oxygen hemoglobin dissociation curve to the left. ADH must be increased, so B is not right. And catecholamine is from adrenal medulla, so C also excluded. And E, the oxygen hemoglobin dissociation curve must be to the right because need for oxygenation.
Yes.
And it's either decreased ventilation perfusion mismatch or increased tidal ventilation. I think A is most appropriate because tidal ventilation, it's a fixed percentage of breathing according to either male or female patient. So I think it's A, decreased ventilation perfusion mismatch.
Okay, then tidal ventilation represents the respiratory rate. Respiratory rate will typically increase in this patient due to chemoreceptor-mediated response.
Yes. I just thought about the anatomical dead space. I'm sorry. Okay, it's D, right?
This is simple.
Because I think ventilation.
Tachypnea. Yes.
Okay, tachypnea. Yes.
Tachypnea is increased. Definition of tachypnea is increased in tidal ventilation. Okay. Increase the respiratory rate and increase tidal ventilation.
Respiratory cycle. Yes. D.
Okay, and here the oxygen dissociation curve will be shifted to the right.
To the right. To the right. Yes.
Okay.
There is hyperthermia, and there is need
We
to
have to remember the word cadet. Cadet.
Yes.
Cadet is shift to the right. Okay.
Cadet to the right.
Cadet to the right. Okay. Then another question. This one.
Right.
No, I cannot hear you well. You have some problem?
Emergency department who has presented with a left side.
Dr. Ghada, you have some problem, I think, with your network.
Okay. Just a minute.
You can fix it.
Okay.
No. Dr. Ghada, do you hear me well? Hello?
You are asked to assess a man in the emergency department who has presented with a left-sided abdominal and back pain, and his heart rate is 130 and blood pressure is 100/70. You suspect a ruptured abdominal aortic aneurysm. Which one of the following is characteristic of hypovolemic shock? An increased renal blood flow, increased cerebral blood perfusion, narrow pulse pressure, raised central venous pressure, widened pulse pressure, narrow pulse pressure.
Okay, what is pulse pressure? Pulse pressure is the difference between systole and diastole. This is a pulse pressure. Okay, Dr. Ghada, I cannot hear you. Then I will clarify the pulse pressure. Pulse pressure is the diastole subtracted from the systole. Systole will be decreased due to decrease the blood volume, and diastole will be increased due to increase the systemic vascular resistance. So the above will decrease and the below will increase. This is called narrow pulse pressure. Okay. And cerebral perfusion. Do you know what's the cerebral perfusion pressure? Okay, I'm going to clarify that. Cerebral perfusion pressure is going
cerebral
according
perfusion
to,
pressure.
okay, you can clarify.
Okay, it's the difference between mean arterial pressure and intracranial pressure.
Yes, mean arterial pressure minus intracranial pressure. In some
Intracranial
books, they
pressure.
add the central venous pressure over it.
CVP.
Okay.
Mm.
Then when the intracranial pressure is increased, then the cerebral perfusion pressure is decreased.
Will be decreased.
But in this patient with hypovolemic shock, the mean arterial pressure will be decreased. So the cerebral perfusion pressure will be also decreased. Okay?
Mm-hmm.
Shall I write the equation? This is the cerebral perfusion pressure equal the mean arterial pressure minus intracranial pressure. Okay? This is the cerebral perfusion pressure equal minus mean arterial pressure minus intracranial pressure. When intracranial pressure increases, this is pi minus, so the cerebral perfusion pressure decreases. When mean arterial pressure decreases, then the cerebral perfusion pressure decreases. So in this case, this hypovolemia, so the cerebral perfusion pressure also will be decreased, not increased. Okay? That's good. Another question. So the correct answer here is narrow pulse pressure. C.
Narrow pulse pressure, yes.
Okay, another one. Okay, narrow pulse pressure. This question. Okay, I will send options.
Okay, you attend a trauma call to a 34-year-old man who has been involved in a road.
Hello, Dr. Agada. I think you have some problem.
Normal blood pressure less than 120 over 80. Normal respiratory rate 12 to 18 beats per minute. What parameters would indicate that this patient is in class 4 hypovolemic shock?
Okay. You have the parameters here. Can you tell me what's the class 4 hypovolemic shock?
Class 4, more than 40% blood loss.
Yes.
Patient will be tachycardia more than 140, and there will be respiratory rate more than 35, and oliguric patient.
Yes.
Not anxious.
Anuric patient.
Yes, anuric,
Yes.
and he's apathic.
Then I'll send
patient.
options.
Mm.
Which of them is class 4 hemorrhagic shock?
Class 4. Okay, pulse rate 92. This is not correct. Pulse rate 111 or 107. Okay, the last one, pulse rate is 148. And
Excellent.
there's hypotension. Yes, hypotension. Respiratory rate more than 35. And urine output 2 ml per hour.
Yes, less than 5. This is right.
Less than 5. So option E.
Option E, yes, is with class 4 hemorrhagic shock. Okay, another question.
You are called to see a 56-year-old man 2 hours after cardiac catheterization. He is actively bleeding from his catheter size, and his dressings and bedclothes are soaked with blood. Which one of the following statement is true? Class 1 shock applies with up to 20% loss of circulating blood volume. Loss of 2 liters of blood is consistent with normal systolic blood pressure. The pulse can remain normal in patients with a class 1 shock, and anuria is a pathognomonic of class 3 shock. Grade 4 shock is seen with 30% loss of circulating blood volume. This option, pulse can be normal in class 1, is true, because grade 4, the loss is about more than 40%, and loss of 2 liters, it's the same Class 4, there's tachycardia and hypotension.
Yes.
And anuria is for class 4, oliguria for class 3.
Yes.
And class 1 shock must be 15 to 20% loss, but pulse can remain normal in class 1 shock is true. See.
C. So the correct answer, yes. The pulse can be normal in patients with class 1 shock. It will be
Yes.
less than 100.
Less than
Okay.
100, yes.
Less than 100. Okay, and as you see, oliguria is a characteristic of the class 3 shock
Yes.
from 5 to 15. Then less than 5 is anuria.
Less than 5
class
is
4 shock.
anuria. Yes,
Okay.
thank you.
Okay, another question. We will take all questions today, Dr. Ghada. Dr. Al-Khan, are you ready?
Yes, sir.
Okay, you can participate with us. This question.
A patient presents with severe left iliac fossa pain, localized peritonism. They have a fast pulse and are hot to touch. Which one of the following physiological abnormalities occurs as a direct consequence of septic shock? Option A decrease in cardiac output. Option B, a decrease in systemic vascular resistance. Option C, a decrease in vascular permeability. Option D, a decrease in intravascular volume. Option E, an increase in cardiac contractility. In septic shock, there is decrease in cardiac contractility. That's why it's wrong. A decrease in intravascular volume. Not, this is not. A decrease in vascular permeability. A decrease in option B, a decrease in systemic vascular resistance.
Yes, excellent. As I said, the distributive shock, which is septic, endocrinal, neurogenic, and anaphylactic, all of them has decrease in the systemic vascular resistance. Okay?
Yes,
In
sir.
this patient of septic shock, there will be widespread vasodilatation due to release of the cytotoxins.
Yes, sir.
So there will be increase the venous return, increase the cardiac output, increase the cardiac contractility, and increase the vascular permeability. All of them are increased, but also the cardiac contractility here has a debate due to toxin-induced myocardial depression. Toxin-induced myocardial depression, so there will be slight decrease in the cardiac contractility. Okay, then the correct answer here is the decrease in the systemic vascular resistance, like neurogenic shock and endocrinal and anaphylactic. Okay, another question.
You attend a trauma call. The patient is a 25-year-old man who has been stabbed in the left side of the chest. The patient is tachycardic, hypotensive, and confused. On auscultation, the chest, there are absent of breath sound on the left, and the trachea is deviated to the right. What is the most likely cause of obstructive shock? Cardiac tamponade, myocardial infarction, pulmonary embolism, pulmonary edema, tension pneumothorax. Patient is stepped on the left side and the trachea is pushed to the opposite side. There is breath sound is diminished. I think patient, there is a massive hemothorax or cardiac tamponade is probably the cause.
Okay, let's clarify the difference between cardiac tamponade and the tension pneumothorax. The most important characteristic feature for tension pneumothorax is shift of the mediastinum to the opposite side. So once there is shift of trachea to the right, means that the left side has tension pneumothorax. So it is pathognomonic for tension pneumothorax. Okay. Then cardiac tamponade is characterized by PICS triad. PICS triad is increased the jugular venous pressure and hypotension and muffled heart sound. You cannot hear the heart sound, and due to pump failure, there will be hypotension, and due to obstruction will be increased the central venous pressure. It is called PICS triad. PICS triad is diagnostic for cardiac tamponade. And once you see there is muffled sound and absent breath sound and trachea is deviated to another side, this is pathognomonic of tension pneumothorax. So the correct answer here is tension pneumothorax. Okay.
Okay, sir.
Another question. Okay, this one.
It's still loading. Okay, sir. You were asked to review a 86-year-old patient, day 3 post-right hemicolectomy for colonic adenocarcinoma. The patient has had their diuretics held pre-operatively and they have not been restarted. On arrival, the patient is in distress and cyanosed. You auscultate fine bivasal crepitation and a portable chest X-ray shows cardiomegaly with bilateral pleural effusion. Which one of the following regarding cardiogenic shock is correct? Should be treated with adequate resuscitation. Option A. Option B leads to a fall in pulmonary capillary wedge pressure. Option C may be treated with sodium nitroprusside. Option D leads to an increased coronary blood flow. Option E has a 20 to 30% mortality rate.
Okay, what do you think is the answer?
With resuscitation, maybe leads to damage the patient heart cardiac condition. Pulmonary wedge pressure, I don't know what it is, and maybe treated with sodium nitroprusside. It will increase the contractility of heart. I think option C is the answer. Treated with sodium nitroprusside.
Excellent. This is right. Okay, clarifying some cardiogenic shock questions. Cardiogenic shock, as I told you, the most common question is acute myocardial infarction to cause pump failure. There is a reduction of coronary blood flow and myocardial infarction, so there is pump failure. I will not give the patient any fluids in order not to cause pulmonary edema more and more. So
yes, sir.
There will be also two characteristics of this cardiogenic shock. They are increased central venous pressure with decreased cardiac output. This is a strong combination of the cardiogenic shock. Increased CVB with decreased cardiac output. Okay, then the will help in this patient is sodium nitroprusside. Sodium nitroprusside is a direct vasodilator agent, so it will cause venodilatation of the efferent of the output of the heart. So it will cause some sort of dilatation and the relief of the afterload. And this will enhance and reduce the systemic vascular resistance and also will enhance the venous return and reduce the obstruction that the heart will face. Okay, so the sodium nitroprusside will help the post preload and afterload. Okay, sodium nitroprusside is also important and as it is a direct vasodilator agent. Okay, another question. Nitroprusside, okay, another one. This question?
Yes, sir. Following a motorbike road traffic collision, a young patient has a heart rate of 42 beats per minute, a blood pressure of 70 by 45 millimeter of mercury, and warm peripheries. His blood pressure does not improve despite of IV fluid. What is the likely diagnosis? Patient IV fluid is not blood pressure is not increased. I think patient may progress to septic shock. Spinal shock and warm peripheries. Due to warm peripheries, I think maybe in the first phase, warm phase of the septic shock.
This patient has bradycardia and hypotension. Okay, bradycardia and hypotension. These are the combination of the neurogenic shock. Causes of neurogenic shock may be spinal shock or vasovagal shock. Neurogenic shock due to spinal cord transection, and this is loss of all sympathetic tone, so the patient will have hypotension and bradycardia. Or the vasovagal shock due to blow to tests or severe bad news you hear, you turn into bradycardia and hypotension. Here the patient has RTA with a motorbike, so may have had severe pelotostis, which can cause vasovagal and neurogenic shock with bradycardia and hypotension. Okay, bradycardia and
Yes, sir.
hypotension. So this is characteristic of neurogenic shock. Okay, another one.
In neurogenic shock.
Neurogenic shock, bradycardia and hypotension. This one.
A patient is spiking fever following a laparotomy for small bowel obstruction. They have a productive cough and forced crackles in the right lung base. They are tachycardic and tachypneic. Which one of the following feature is not present in a patient with septic shock? Increased systemic vascular resistance, a systemic inflammatory response syndrome, hypotension, tachycardia, organ dysfunction. Organ dysfunction present in septic shock. Tachycardia is present also. Hypotension, yes, hypotension present. Systemic inflammatory response syndrome. Systemic inflammatory syndrome is the before presentation of septic shock. And increased systemic vascular resistance. I think A is the increased systemic vascular resistance.
Excellent. I say decreased systemic or peripheral vascular resistance occurs in the distributive shock, which is septic, endocrinal, neurogenic, and anaphylactic. All of them has decreased systemic vascular resistance. So in septic shock, there is decreased systemic vascular resistance. So answer A is correct. Another one. Okay, this question.
Yes, sir. A 32-year-old man is bleeding profusely from a stab wound to his right thigh. His pulse is 122 beats per minute and blood pressure is 90/60 millimeter of mercury. He has a delayed capillary refill time and appears confused. Which class of hypovolemic shock corresponds to these vital signs? Heart rate is 122. It is respective of class 3 shock, and blood pressure is 90/60. Capillary refill time is confused. Patient is confused. That's why I think patient answer is C, class 3 shock.
Excellent. Once there is hypotension, so it is class 3 or 4, no class 5.
Yes, sir.
Okay, class 3
Yes,
or
sir.
4. And the heart rate here is more than 120 and less than 140. So it is class 3
Yes,
shock. Excellent. This question.
Yes, sir. A 21-year-old man is admitted with accident and emergency with a stab injury to his abdomen. He is hypovolemic shock with a pulse rate of 180 beat per minute and blood pressure is 70/40 millimeter of mercury. Which one of the following fluids would be the most appropriate? Dextrosaline is a good choice for blood fluid resuscitation. No, it is not. Folate is adequate for treating hypovolemia due to loss of intestinal fluid. No intestinal fluid loss, we can Ringer's lactate or Hartmann solution. It is best to use whole blood to treat hemorrhagic in trauma cases. I think it's the right choice. Gelofuscin, and which contains a high level of potassium. I don't know. Normal saline, which contain 132 millimole of sodium. Now normal saline contain 150 millimole of sodium. I think it's best to use whole blood to treat hemorrhagic shock in trauma cases. It is option C in the cases.
Excellent. It is better to use whole blood or fresh frozen plasma to pack the RBCs to platelet by 1:1:1. Pack the RBCs to platelet to fresh frozen plasma 1:1:1, or to use the whole blood in patient with hemorrhage. When I am treating class 3 and 4 hemorrhage, I use blood or fresh frozen plasma, packed RBCs, and platelets. Okay, but colloid is not the treatment of a choice for hypovolemia. It will exaggerate the response, it will increase paradoxical augmentation of the third spacing with increase the vascular permeability. So colloid is not preferred for that. Okay. Then
Yes.
the also choice A, the fluid for resuscitation is the Hartmann or Ringer lactate. Hartmann or Ringer lactate. Okay. Then normal saline contain sodium. What's the percentage of sodium in normal saline?
153 millimole per liter.
153. Okay. Another question. Another question. Okay, class 3. This is an important one.
Yes, sir. A 36-year-old man was brought to the accident and emergency department following an automobile accident in which he suffered a pelvic fracture with significant internal blood loss resulting in hemorrhagic shock. Which one of the following organ is especially vulnerable during the shock phase in this patient? Brain, heart muscle, kidney, skin, skeletal muscle.
What's the most important?
Skeletal muscle, not skin. There is a kidney, heart muscle. Kidney, most probably.
Yes,
Option C.
right.
Yes.
Right, kidney. Okay, the distribution of the blood supply to each organ will form L,
Yes.
K, M. Here is the liver, 25%. Kidney is 21%. And muscles, 15%. And brain, 15 also. Okay, then the skin and heart will be 5%. You should remember this. Liver, 25,
Yes,
kidney is 20, muscle and the brain, 15, then the heart muscle and the skin is 5. Okay, this is an important. Okay, I'll go for another question. This one.
Yes, sir. You were called to review a patient on the high dependency unit day 1 following a laparoscopic hemicolectomy for colorectal cancer. The nurse tells you that the patient is in shock and shows you a patient's observation. Which one of the following statement is correct regarding shock? Option A, septic shock produces high systemic vascular resistance and high cardiac output. No. Cardiogenic shock produces a low systemic venous return and low cardiac output. So high systemic neurogenic shock
Yes.
can occur after general anesthetic. Yes, it can occur. Spinal anesthesia, no, probably. An anaphylactic shock produces a very low lactic acid level. Septic shock produces a high systemic venous return and low cardiac output. Septic shock produces a low systemic venous return, high cardiac output. There is option E is wrong. Anaphylactic shock produces a very low lactic acid level. Due to anaphylactic shock, there is maybe high lactic acid production due to there is vasodilatation. Neurogenic shock can occur after general anesthetic. Is it the option C?
Okay, then you choose
C.
C.
Neurogenic shock. Yes, sir.
Okay, excellent. Right. Then by exclusion, A, septic shock, as we have reduced systemic vascular resistance, not high. So A and E
Yes, sir.
are out.
Wrong.
Okay, then B, cardiogenic shock cause high systemic vascular resistance and low cardiac output. So as you remember in the previous questions, I give sodium nitroprusside to decrease the systemic vascular resistance in cardiogenic shock. Okay, yes. So in patient with cardiogenic shock has high systemic vascular resistance and high central venous pressure with low cardiac output. Neurogenic shock can occur after any type of anesthesia, general or spinal anesthesia. Okay. Then anaphylactic shock, which is in the form of antigen antibody immunoglobulin A reaction and causing widespread vasodilatation and anaerobic pathway, so characterized by high lactic acid level. Okay.
Yes, sir.
And option E, like A. Another question. Okay, if anyone also want to participate, Dr. Noor.
Hello, sir.
Hello. Okay, you can continue.
Yes.
Okay, another question. This one.
A 32 years old man is brought to the emergency department following motorcycle accident. On initial assessment, there are obvious bilateral closed femoral fracture. On observation, his observation of pulse rate is 134 beats per minute and blood pressure is 82 per 42 mm of Hg, reduced pulse pressure, and respiratory rate is 34. Which type of shock it is? Sir, it is a hypovolemic shock class 3.
Excellent. This is class 3. Once there is hypotension, it is class 3 or 4. Then I'll go for the pulse rate, which is more than 120 and less than 140, so it is class 3. Another one.
A 21 years old.
No, this is repeated. Sorry. Okay. This one.
A 19 years old man is admitted to the accident and emergency resuscitation unit following a stab injury to his abdomen. He is in hypovolemic shock. Which of the following is true? Dextran administration prevent a fall in hematocrit level. Excessive crystalloid administration is associated with ARDS. Hartmann is the fluid of choice to correct an ongoing hemorrhage and hypotension. Initial volume expansion is more quickly achieved with crystalloid than colloid. Strong stored blood have high pH. Sir,
what do you think?
So Hartmann is the fluid of choice for, but sir, excessive crystalloid administration is associated with ARDS. I will go for B, sir.
Excellent. You are excellent. That's right. Okay. Excessive crystalloid administration is associated with acute respiratory distress syndrome. Acute respiratory distress syndrome is some sort of non-cardiogenic pulmonary edema, which is characterized by refractory hypoxia and inadequate lung oxygenation, and pulmonary artery wedge pressure is less than 18. Okay. Then excessive crystalloids causing non-cardiogenic pulmonary edema and ERDS. Then option A, dextran prevent a fall. No. Hartmann is the fluid of choice for ongoing hemorrhage and hypotension. I said before, whole blood or packed RBCs to platelet to fresh frozen plasma 1:1:1. Okay. Initial volume expansion is caused by colloid more than crystalloid, not crystalloid more than colloid. Okay. Then the last one, stored blood has a low pH, acidosis, low pH. Okay. Another one. This question.
Shock is due to circulatory failure. There are several important etiologies to be aware so that they may be recognized and promptly reversed. In which of the following type of shock is the primary problem due to loss of peripheral vascular resistance mediated by toxin? So it is septic shock.
Excellent. This is a simple question. Simple question. Decreased vascular resistance. You see that about 17 questions from the 18 are telling the septic shock has low systemic vascular resistance. Okay, another one. The last question.
A 35 years old maintenance engineer falls from a flagpole and is admitted with a head injury and is profoundly hypotensive. They are also complaining of neck pain. Which of the following regarding neurogenic shock is correct? Cause decreased cardiac preload, is characterized by tachycardia, is associated with cool peripheries. D, lead to narrow pulse pressure. E, there is compensatory rise in systemic vascular resistance. Sir,
I tell before, neurogenic shock, all are decreased. So decrease the cardiac preload, decrease the cardiac output, decrease the heart rate, decrease the blood pressure, and decrease the systemic venous resistance. Okay, in neurogenic shock, all are decreased. So decreased cardiac preload is a character of neurogenic shock. Okay, but the patient will have warm periphery due to vasodilatation and has bradycardia. Okay, and decrease the systemic vascular resistance. Okay, thank you all. I have finished. Now thank you. All of you have good benefit.
Yes, sir.
Okay, thank you. See you soon, inshallah. At Friday, we have a session about fractures and dislocation. It will also be an interesting session. See you all. Goodbye.